Helena specializes in treating patients with neurologic and balance and vestibular conditions. She earned a psychology degree from Northwestern University and graduated cum laude from Marquette University's doctoral physical therapy program in 2005. After 8 years in acute care, she developed a vestibular program. Dr. Helena transitioned to outpatient care in 2014, gaining access to infrared video goggles that enhance her ability to treat complex vestibular cases. She achieved vestibular competency at Emory University in 2015, certification in cervicogenic dizziness in 2016, and became a neurologic clinical specialist in 2018. So that's very famous and very outstanding for us, the specialist here in America. We are different in specialization. We have neurologic, orthopedic, and geriatric, and more. But Dr. Helena will be focused, and she's specialized in neurologic. And just a side note, the vestibular and video goggles that you will learn more today is from the amazing brain of her amazing spouse, and then Patrick, and he's one of the board with us with the APTA. And she presented in numerous conferences, including Penn Medicine, Mind for Your Brain Conference, and of course, lots of volunteers. All right. Okay, I give the floor to Dr. Helena. All right, let me see if I can highlight you. And here. Welcome, Dr. Helena.
Thank you. Hello, good morning and afternoon, and everyone, wherever you are. And thank you for joining us. And thank you, Dr. Jenny, for hosting this. You're always doing a wonderful job sharing information amongst clinicians and patients. And I think that's just really valuable. So we appreciate you.
Thank you. My pleasure. I give the floor to you. And guys, if you have anything to ask or later in the presentation, you have the QA portion there to chat, and I can guide you to ask those questions. If you want to talk for short, maybe I can allow you to talk if it's really a long explanation. And we have the chat room. Go ahead, Dr. Helena. Thank you so much.
Perfect. Yes. So I have the so not easy topic of differential diagnosis of vertigo today, and I only have about 40 minutes. So understand that this is not completely comprehensive. This is not a vestibular course. I'm going to have resources for those who are clinicians that would want more. Absolutely happy to support you there. But I'm going to kind of use some case examples and just try to cover some of the concepts for everyone so that we can grow. So I've been introduced. I am co-founder of Vestibular First, and we are today going to discuss primarily benign paroxysmal positional vertigo. We'll be defining that because that is the most common type of vertigo. So that is the one that people tend to talk about the most. We will briefly cover how to do some assessment, including use of visual fixation remove testing, which is using infrared video goggles. And we'll go through some practice cases with eye movements as part of the assessment, which are really key so that we can identify the diagnosis and therefore choose the proper treatment. And if you've ever had vestibular rehab and you said, well, I didn't work, it may be that you didn't have the right treatment. And this is not to judge any clinician out there who tried to help you. Vertigo is not always a simple thing. I'll be honest. It can be complicated. So the goal is to try to learn more all the time. They're always doing more research so we can do our best job to help deal with these challenges. So we're going to start just really briefly with the anatomy to get everyone on the same page. I feel that's very important with these discussions. So what is the vestibular system? We primarily mean our peripheral inner ear balance sensor. So you see that little pink guy with the 3 canals. Here he is made bigger for us to see better. We have several educational tools available through Vestibular First for this reason, to try to understand this little apparatus. In real life, it is not this big. It is actually very tiny, about half the size of a dime, and it lives as a neighbor to hearing structures. So when we look at this little guy, it's really just these 3 little canals in the center area near it. But that kind of curly Q looking snail thing, that's actually a hearing structure. So you can see that the vestibular apparatus and the hearing structures are very close neighbors. Now, that means that some issues, we'll have hearing symptoms and dizziness or imbalance when we have problems in this area. But other times, if only the little sensor is affected and not the hearing structures, we might only have dizziness and imbalance, but not hearing symptoms. So this is, again, where you can have different presentations depending on what structures are being affected. And so when we think about the different parts of the ear, the part that we all know and love is on the outside. That's our outer ear. That part is, really cool to look at, but it doesn't help us with hearing or balance at all. Well, it does bring in the sound a little bit. We should give it some credit. But the middle ear is where those little tiny bones for hearing live, and it's the inner ear that's embedded in the bone on the side of our head, the temporal bone, where we have this vestibular apparatus and some of these other hearing structures. So let's talk a little more about this little guy. So we have a few different sensors to help us sense up and down movement, lateral movement. Those are the otolith organs, or utricle and saccule, little collections of cells, have a really important job. And then our semicircular canals. So they're going to be really important to this discussion. So let's be familiar with them. Anterior goes up, like at the St. Louis Arch. Horizontal is roughly parallel with the ground when we're standing up. And the posterior canal kind of tilts back. And so we have this kind of apparatus designed this way. I believe that whoever designed it, or if it was just luck and evolution, but somehow it developed the ability to sense direction of different motions. Are we rotating? Am I leaned over? Where am I in space? And the brain really likes to know where we are in space to keep us safe so we don't fall and things like that. And when we talk about specifically problems with the inner ear, it's important to know some of these kind of more intricate structures within the canal. So you can see there's a membrane here called the cupula. I call it like a trampoline. It's attached all the way around. And we have a cupula at the end of each of our three canals. And those cupula live inside this kind of lumpy area of the canal called the ampulla. And then we have what's called the long arm, this kind of big, long, curvy tube. Okay. And then we have what's called the short arm of the canal, which is just this little space in here, but it is its own space. Now there's openings in between this short arm and this kind of center area. This is where the utricle is, just as a reminder. But nothing can pass through the cupula unless there was significant damage to this structure. But otherwise, that cupula blocks things. And this is a good thing because it provides it with the ability to function, but it also can be a challenge when we're talking about certain conditions to try to treat. And then where the anterior canal and the posterior canal meet in kind of a common tube, that's called the common crus. Crus like cross, we all know that word, right? So you say, Helena, right out the gate, you're hitting me with anatomy, but if we don't understand the anatomy of the system, it'd be very difficult to treat it properly. So this is why I'm waking you up for those of us who it's early, for those of us who it's later, that's better for you. So what is BPPV? So this, again, the most common cause of vertigo in patients, especially adults. The initials are as follows: B for benign. So even though it can feel terrible to have this condition, because when these crystals go out of place, we're going to talk about that in a second, you can feel a lot of symptoms with this condition, but it's not a tumor. It's not something like a stroke. It's not going to significantly harm you unless you fall and get hurt. But it feels not good, right? It can feel like you're spinning, very off balance, things like that. But in a sense of seriousness to the body, it's considered benign. And then paroxysmal means that you can feel the symptoms suddenly. And sometimes these symptoms will recur, unfortunately. And you will feel these symptoms with a change in position typically. So a big report is I was turning over in bed and then the room started spinning, or I went to sit up and I started feeling off balance, and I went down to put on my sock and I started spinning again. So these are the kind of the most common reports of this condition. And then this vertigo word, this V in the BPPV, it typically means folks will feel a sense of self-movement, or again, the room might be spinning, something like that. But I will tell you that many patients who have BPPV do not feel BPPV this way, unfortunately. So It's a little bit of a misnomer in my mind because people say vertigo and they think it's always spinning. But unfortunately, the descriptors of symptoms are not always clear cut. And we really have to look at our physical exam to figure out if this is what's going on to cause this patient to have some sort of symptom, or is there something else going on that we need to address? So the big kind of description of BPPV that I like to give is the crystals are out of place. And you say, whoa, Helena, this sounds a little odd. What do you mean crystals? Well, in that anatomy, I'm going to go back to one of my earlier slides. You can see this little picture here. These are crystals out of place. Where are they supposed to be, you say? They're supposed to be in the middle in what's called the utricle here. So I mentioned the utricle briefly, and both the utricle and saccule actually have crystals that are embedded in a gel, and they help us sense gravity in a nutshell. So these crystals are supposed to be there, but they're supposed to stay in place. Sometimes they will break loose and they will float in the fluid that fills this whole system, and they will kind of sneak their way into one of these three canals, or sometimes more than one canal, unfortunately. So when that happens, the person might turn in bed or whatnot, they move, the crystals will shift in that canal where they don't belong, and that creates movement of the fluid in the system, stimulates that membrane, that cupula, and it makes the person feel like they're moving a lot more than they actually are. So it's a false sense of movement. They might even get nauseous with it, and they might throw up. So this is what we see with this condition sometimes. So the treatment is what attracts a lot of people to vestibular rehab as clinicians, because if you do it right and you put those crystals back where they belong, the person can feel better pretty quickly, and that's really cool. So I like to say it makes the clinicians feel like they're the magician, like, oh, magically I fixed you. And there's not a lot of things in rehabilitation that are a quicker fix. So this is a very attractive thing to want to fix if it's present. So what canals can be affected? The answer is any of them, but most common is the posterior canal. A close second is the horizontal canal, and a distant third is the anterior canal. And sometimes it's really a tough case to figure out. So in this study that we pulled this data from, which was on like 4,000 or 5,000 patients, there were some that was just not able to be clearly defined. But the majority are going to be your posterior canal. And that is what I'm going to focus on today. I am not saying that the horizontal canal is unimportant, however, but I don't have time to cover both. So I picked one. And if you want to learn more, again, I'll have resources for you for how to assess and treat the horizontal canal properly. So when we talk about these crystals, sometimes they're floating and sometimes they get stuck. So we have different terms for that. They're big, long terms. So canalithiasis is the term we'll use for floating. Otoconia, they're kind of in a canal. And cupulolithiasis means they're stuck. Now, they might be stuck to that membrane itself, like rocks glued to a trampoline, or they might actually get stuck like a clogged pipe. So they might kind of jam the canal. And it's not always clear which is happening, but as long as we free them and get them back where they belong, it's fine either way. So we just got to figure out how to get them back, and that's the important part, wherever they're stuck. So I want to point out here that I mentioned that a lot of patients will feel like they're spinning, off balance, but some patients actually have very little symptoms except perhaps falls. And so if I have a patient come into my clinic and they tell me they've been falling and they don't really know why, I always screen for BPPV. They do not have to say they're dizzy. They do not have to say they feel like they're spinning. That is not necessary for BPPV to be present. And we should be checking for this because it doesn't take long to check for it. And if you catch it and you treat it, that decreases the risk of falls by 64%. That's a very powerful number for a very immediate improvement in balance. So recent literature led by Sue Whitney and her team of researchers have found that experts recommend that all older adults more than 60 years old with objective, meaning I can measure it with a balance test, or subjective, I feel off balance, problems, regardless of their symptom complaint. Doesn't matter if they say they're dizzy or have spinning. They should all be positionally tested to examine for BPPV. This is the recommendation. So I'm pretty passionate about this because it's a powerful thing. And what's tricky about this condition is it can come and go. So you could come into my clinic today, you're feeling off balance, I check you for BPPV, I find it, I put the crystals back where they belong with some head and body movements, And then 2 months later, you're feeling it again, or a year later, you're feeling it again. You need to go back and go to see not necessarily me, but someone who's like me, who's trained, someone who knows how to check for BPPV, check it and treat it if it's present. Very, very important. So we don't get unnecessary falls that can lead to injury, broken hips, things like that that we worry about. And they've actually found that amongst community dwelling people over the age of 65, they just took a big group of them. None of them said they were dizzy, and about 9% were found to have BPPV. That's, 1 in 10 roughly. So that's a pretty big number of people that aren't even complaining of dizziness or vertigo. And then you've got your group that are, and lots of those folks have BPV as well. So we really want to be checking for this. All right. You guys are doing great. All right. So how do I know where the crystals are out of place, you say, Helena? Well, we have tests for that. And one thing that we're looking for is an eye movement, a special eye movement called nystagmus. So nystagmus is an eye movement that has a quick component and a slow component. So again, this is going to be, if you're brand new to this concept, don't feel like you have to learn all this now. I'm going to give you courses to attend. You're going to need more, I can tell you, but this is just giving you a sense of it. So the eyes will do certain eye movements, tell me that the crystals are out of place, and the direction of the eye movements tell me which canal, right? Because I don't just want to be treating every canal. That's silly. So we're going to test, let's say, the posterior canal, and I'll show you that test in a second here. And then you're going to look for a characteristic eye movement that says, yep, they're out of place on that right posterior canal or what have you, versus testing the horizontal canal. You're going to get different eye movement if there's crystals out of place there. And so here is kind of a summary. I'm big into summary charts on where could the crystals be out of place and what type of nystagmus I would be looking for. So posterior canal versus anterior canal versus horizontal canal. And remember, it can be floating or stuck, and that can affect how the nystagmus presents as well. So I'm not going to get all in the weeds here because, again, this is a vestibular course that we need to really learn this. Okay? What's that, Jenny? Dr. Jenny?
Sorry, I'm just putting what is kind of torsion
Oh
and
yes, all the nystagmuses. I know, right?
I'm
There's
sure.
so many. There's so many. I'm going to show you some videos because videos are worth 1,000 pictures or me moving my finger to show the nystagmus. But you're totally right, Dr. Jenny. The eyes
Yeah.
do dance. Some people call it like a dance
I'm
that they
reviewing
can do.
myself, that's why, sorry.
I love that. I love that. Everybody review like Dr. Jenny. All right. So the eyes move because we have muscles attached to our eyes and because there's a strong relationship between the eyes and the vestibular system. And this is called a vestibulo-ocular reflex. So it's a really cool neurologic reflex that allows us, when everything is normal, to keep my eyes on something, even though I'm moving my head all around. So really my eyes and my inner ear have to work as a team, not only for balance, but to stabilize my gaze. So this kind of important relationship that we rely upon because when there's something wrong with the vestibular system, we get these funny eye movements. And because the vestibular system lives deep in the inner ear, you can't just take a picture of it with an MRI and know that there's crystals out. It's not like that. And remember, the crystals are super tiny. They're like microscopic. So that makes it tough too, because you got to figure if the structure is only half the size of a dime, the crystals are like smaller than a thread of your hair. You wouldn't be able to see them without a microscope if you had them in front of you. So when we talk about looking at eye movements to help us diagnose BPPV or other vestibular issues, it's always in relation to I'm facing the patient. It's the patient's right or the patient's left or the patient's up or the patient's torsion to the right or left. So we have to kind of reverse it in our mind, and that takes practice. Once you get good at it, it's like automatic. But in the beginning, you might need to kind of label it for yourself. I have put post-it notes on my screen of my computer before. Goggles have them sometimes already labeled, so you know which one is the person's left or right eye. So you know it was a left bead and not a right bead or what have you. So here's an example of an eye movement we might see for nystagmus in a right posterior canal. So this is considered right up torsional. You can see there's kind of a rotational component, like a clockwise, counterclockwise type idea, as well as a little bit of upbeat, as well as kind of pulling a little bit to the right. And we can even use gaze to help us really clarify if there's an upbeat component, if there's a rate pull a little bit. So that can help us with our diagnostics. So I have superimposed, well, I'll give Patrick, my husband, co-founder and technical guru, credit here. He has superimposed a crosshair just to help us see better that this is a real patient's eye that's having some right up torsion, which is a common presentation for someone with right posterior canal, BPPV, where those crystals are at a place in that right posterior canal. So how do we figure this out in detail? Well, Helena, wait a minute. There's all these other conditions that aren't BPPV. I know, but I don't have a day or 2 days. I only have 40 minutes. So I just want to give you kind of some common ones here listed. And know that asking questions can help. So for BPPV, just as an example, I can't read this whole chart out, but just for BPPV, if the person really feels symptoms turning in bed, that's a high likelihood, not a definite, but it's a high likelihood of BPPV. You can see this big orange chunk here. All right, and that proves out true again and again as you go further down and see again if they have dizziness turning in bed. High likelihood, not a guarantee, but high likelihood they have BPPV. So this is just a way to kind of look at how asking the right questions might help us figure out a diagnosis. Now, we still want to do our physical exam, but it's good to know the answers to some of these questions. So this is a nice study done by Strobel et al. That you guys can check out if you want to learn more. Now, I'm not going to read this chart out to you either, but I want to let you know that if you think a person might have damage to their vestibular nerve on one side or both, which would be a unilateral or bilateral vestibulopathy or hypofunction, there are some tests that you should learn, if you don't know them already, to help you identify that as a likely issue. Whereas someone, if it has Meniere's disease, which is intermittent swelling of the inner ear, they absolutely need a hearing test because in order to meet the diagnostic criteria, you must have low to mid frequency, a very specific kind of hearing loss in order to fit that criteria. And there are diagnostic criteria for many of these other conditions, as you can see. So again, this is not a 2-day course or a week-long course, but at least it gives you a sense of how might, as a patient or as a clinician, might I start to figure out what's the cause of my vertigo? This is what differential diagnosis means. What's the cause? And bad news is sometimes two of these conditions are present at the same time. So that makes it even a little bit stickier, right? So in fact, vestibular migraine is an example, which is a type of migraine that is less about headache and much more about dizziness. So the patient may have very little headache issue, actually. I know people sometimes think migraine just means headache, but actually can primarily mean dizziness. It's very common to get BPPV. It's a kind of a risk factor for BPPV to have vestibular migraine. So I might have someone coming in and it sounds like they have vestibular migraine based on the diagnostic criteria, but I'm still going to check them for BPPV because if that's there, I can treat that right away. And we still are going to do some ongoing medical management and vestibular rehab for the migraine component. So this is where our differential diagnosis, we need to think broadly, think about everything we're seeing and hearing and what makes sense. And it may not be that we figured out in the first session. So don't feel bad about that as a clinician. It can take time for some of these conditions to really show themselves over time with pattern. So we look for that. So let's go back to BPV because that's our easy fix. So it's easy to talk about compared to some of the others, but it can get tricky. So the clinical practice guidelines by Bhattacharya et al. In 2017 still stand strong. And they highly recommend checking both posterior and horizontal canals. I mean, you're going to check anterior canal as you're checking posterior canal. Just don't think we're neglecting anterior canal. But remember, that's really rare. So we're really focusing on these two as our primary likely culprits. And you can see here on our right, this is the common test for the horizontal canal is this supine roll test, where we're turning the head gently to the right or left. And if you don't have neck range of motion, you can just roll the body. So there's always ways to accommodate this testing. There's very few reasons why we can't do it. And sometimes if someone's medically unstable, we would wait. But there's certainly lots of opportunity, even if there's limited neck range of motion, to test for these. Some of you, as clinicians or patients, may have heard of something called meclizine. It is the most common vestibular suppressant given. I compare it to pain medicine. I have a broken arm. Here's your pain medicine so it doesn't hurt so much. Does that heal my arm? No. So meclizine is not a bad thing, but it actually is not the best treatment for something like BPPV. They do not recommend that be prescribed. that we really should be doing maneuvers and clearing these crystals. And actually, even if someone has something like damage to the inner ear, that vestibular neuritis, vestibulopathy, if we give meclizine for more than a couple days, it actually blocks the ability of the brain to help take over the job of the inner ear that was damaged. So meclizine is not a bad thing, but it's really not something that we should be taking long term. So if you're a patient on that, I'm not saying get off of it. I'm saying talk to your doctor and hopefully have a vestibular specialist that you're working with to see if we can kind of have other treatments that are appropriate to address your dizziness aside from the meclizine, which may or may not really be helping, to be honest. Also, it is important, according to the guidelines, for clinicians to feel comfortable differentiating positional vertigo, that BPPV, from general inner ear issues like a vestibulopathy or Meniere's disease, from brain problems like vestibular migraine being one example. So we really need to make sure that we're not just treating every vertigo and every positional vertigo. Oh, it's definitely BPV. No, we have to do our exam, do maneuvers. If the maneuvers are not changing the symptoms and the nystagmus that we're seeing, it's not BPPV. So that's one of the things we have to think about is this responding to treatment? Because there's unfortunately stories of patients who have had repositioning maneuvers once or twice a week for 6 months. That is not appropriate. There's something else going on if that's not resolving your symptoms, or the maneuvers are not the right ones for your BPV, I suppose. But you really need to be kind of taking a second look. So I'm just going to spend 1 or 2 slides on goggles. So this is really an essential tool because unfortunately you lose about 2/3 of the abnormal eye movements in someone with vestibular pathology of any kind, including BPPV, if you're not blocking light. So what the goggles do is they're dark inside. So the clinician will put the goggles on. It's dark to the patient. There's infrared cameras inside so that the clinician can still see the eye. You can see there's kind of a display because the goggles are attached to a computer so that we can see, is the eye moving? What direction is it moving? And how is the eye moving in different ways depending on where I've put the head, where I've put the body, would I shake it and then stop? What happens? These are certain specific tests that we're looking at to help with the diagnostics. So the good news is these used to be very expensive, but Vestibular First, one of our missions is to make them affordable. So they're currently priced at $2,600. That's, in end of 2024. So we're really trying to keep that price as close to that as we can in the future, but we'll see what we need to do from a practical perspective. But ultimately, the other ones that are out there are $10,000 to $20,000. So we're really trying to keep them affordable. This is my mission because I believe that every person should be checked for BPPV. So we need lots of clinicians who know how to do it, but then all of those clinicians should have the right tools or they can't do their best job. They're guessing, they're missing things, and then we're not able to help these patients properly, reducing the risk for falls, things like that. So this is what we want to be able to do. And there are experts in the field, it's not just me, that state this very clearly, particularly when you're looking for a peripheral nystagmus, so that would be BPV or a hypofunction. These types of nystagmus can suppress in room light. So they feel that, quote unquote, nystagmus goggles are essential for any clinician dealing with dizzy patients. So if you don't know who Dr. Michael Hamagi is, he's a fantastic ENT physician out in Australia, and he's been studying the vestibular system well longer than I've been alive, and I'm not super young. So yeah, he's been doing it a long time. So what does BPV look like? You say like, okay, I feel dizzy when you turn in bed. Okay, that's fine. But there's more to that. We got to look at the nystagmus. So the nystagmus should be provocable with our positional tests. The nystagmus should occur and kind of crescendo and then decrescendo. Okay, so if it's just like a constant mild nystagmus, that might be the brain talking, or an old hypofunction or something like that. So we want to differentiate, are we getting that crescendo, decrescendo? And if we try treatment and then we retest after a rest and we've resolved the nystagmus after a few rounds, great. If they still feel a little off balance, they might need a little bit of vestibular rehab to desensitize to motion or some balance training that's appropriate in the literature. If we don't change that nystagmus at all after 3 to 5 good rounds of treatment, and that's like a full session where I'll probably at least do 3 or 4 maneuvers if I have time, then I need to be referring back. We really need to be kind of making sure we're not mistaking a nystagmus as BPPV when really it's a tumor. I mean, that's rare, thank goodness, but we don't want to just jump that everything that we see during a positional test is not necessarily BPV, is what I'm saying. So we're just kind of reminding ourselves of that as we go. So how do we test for it? The most popular test, been around a long time, the Dix-Hallpike, fantastic. Turn the patient's head toward the side you want to test, about 45 degrees, lay them back. This can be modified with pillows and other things if the patient doesn't have a lot of neck range of motion, no problem. And we're just trying to get the head in this kind of little bit of extended or rotated type position. And we're watching for a nystagmus that comes and goes. Or it might just kind of get really strong and then kind of just stay there. If it's stuck, then you might kind of see a persistent little bit of nystagmus that can happen as well. And then we look for any symptoms that are associated, which, most of the time there will be, but sometimes remember that patient may not feel it at all. It's called vestibular agnosia. It's a fancy term. And it just means the patient will be like, I don't feel anything. And the eyes are doing this. And then they stop and you're like, well, that's acting like BPV. Let me try to treat that and see what happens when I do a proper maneuver. Do I clear that nystagmus or does it stay? So recently in the literature, for those who are clinicians, there is a way to increase the sensitivity. So increase the accuracy of your testing. In addition to using visual fixation removed or with the goggles, we can load the Dix-Hallpike. So this comes out of research with Jeff Walter, who's a fantastic vestibular educator and clinician and researcher in his group. And so you basically turn the head towards the affected side, just like the regular Dix-Hallpike, but you want to tuck that chin towards the chest about 30 degrees if they have the range. And you're going to leave them in that position for 30 seconds. And what that's doing is it's basically dropping any crystals that are out of place in the posterior canal or anterior canal kind of forward into a clump. So then when you go into this extension, you're going to drop that big clump and you're going to get a nice burst of nystagmus. So do not use this if the patient is coming in and I'm like, I'm so nauseous, I've already thrown up. You don't need to load those people. But anybody who's, maybe like, oh, it was really bad the other day, but now it seems like it's getting better. Maybe they only have a little bit of crystals left. Absolutely load those folks. All right, so a little tip for you, load the Dix-Hallpike for most of your patients. I've found it to be very successful in my practice. All right, so how do you tell if it's floating or stuck in the canal? Because again, that's going to change your treatment choice. If it's floating, the nystagmus will last less than a minute, and the symptoms will probably be lasting about as long as you see the nystagmus is typical. So you're doing this Dix-Hallpike test, you look for that nystagmus, the lasting less than a minute, and it's like torsional and upbeat towards the affected side. So this chart is giving a left-sided example. We think it's left floating. If it looks like a downbeat with a little bit of torsion or a straight downbeat, but it still comes and goes, it could be either in the anterior canal, which remember is really rare, but it does exist. We know it does, 2% of cases. Or it can be that short arm. Remember I said there's a little piece on the other side of the cupula of the posterior canal? Sometimes the nystagmus will be downbeat because it's in that little area, and that has to do with the way the cupula is getting pulled. But we don't have to get into that. Just trust me on this one. I've read the literature. So if you see a downbeat that's short in duration, it still could be BPPV. So we want to at least try to treat that. And then if we don't change it at all with maneuvers, we might think, oh, maybe this is brain talking and there's something else going on, like vestibular migraine can create a downbeat as well. All right. Now, if it's stuck, the nystagmus will last more than a minute, and it'll probably just keep kind of beating a little bit consistently. So you see my example here, very similar. Now, the answer for can it get stuck in the anterior canal? Nobody's proven that. They think it's either exceedingly rare or it might not exist. So if you see a downbeat that lasts and lasts and lasts, suspect the brain, because almost always there's something going on, whether it's a lesion in the cerebellum from an old stroke, or it's somebody who has vestibular migraine or some other brain issue that's causing that nystagmus. So just keep that in mind, that it's very rare to have it stuck in the anterior canal. So that persistent downbeat would be rare. All right, so here's our classic. I promised you videos. Here's a classic left posterior canal test. So we're doing the Dix-Hallpike. And credit to our people that made this video. So we're doing a turn to the left. We're going to bring this patient back with a little bit of neck extension. And inside the goggles, what's happening? On both eyes, it's doing this. So the patient's like, oh, I feel it. And you see that nice line on the iris. You can really see how there's this brisk left torsion. And you're like, left? Yes, it's the patient's lest us not forget. So that would be a very classic presentation of someone with left posterior canal because it came and then it slowed down and then it stopped. Right. So those crystals shifted, we got that movement, and then they were done shifting, and so they settled. Now, the most popular treatment, been around the longest, is the epley. And so the epley, you're going to have the patient turn their head, lay back in the Dix Hall pike, and then you turn their head 90 degrees away from the affected side. You have them roll over, nose down, and then you have them sit up, and you're going to do a minute or two in each of these positions. So again, this is something you can learn in a course, so we're not going to be able to physically practice it right now, but just understand that there are common treatments here, and there's always science happening. So they've actually found that if you modify the position on the third position with the nose down to more rotation than they used to do, you can get a better result. So this is the cool thing about science, is that even something as classic as the epley, doing it a little bit differently can get a better result, they're finding, with science over time. So keep that in mind, and don't get frustrated if it's not responding to maneuvers. Maybe you need to modify what you're doing. Don't just keep doing it the same way multiple rounds. That is not a good plan. If you do one round and you got it cleared, great. You do a round and you didn't get any change, try it differently, or try a Samant, which is another treatment. There's something new out there called the Diaz. I mean, you got so many choices. All right, so let's look at this patient. They're in a Dix Hall pike and they're getting a downbeat. So you're saying to yourself, is this anterior canal? Is this the short arm posterior canal? Possibilities. Okay. So if it's in that short arm, again, we can get this downbeat. And that's what we suspect with this patient because they responded to a treatment called the Bascal. This is brand new. This actually is not even published yet. This came out of the Baronnet Society meeting that they had in August. So I pulled it for you guys. I put this here. You don't have to memorize it right now. I'll make sure all these slides are available. But understand that there's a cool new maneuver. If you see that downbeat, you could try this maneuver to see if that'll clear these kind of more stubborn cases. When it's caught in that short arm, it can be really hard to get out. Dr. Jenny, you got something? Doing good?
Yes. Mm-hmm.
Good. All right. So here's another patient example. Now this patient is presenting, I'm treating her right, or I'm assessing her right side. So I've got her in the right 6 Hall pike. She gets a nice brisk right torsional upbeat nystagmus, pretty classic right posterior canal presentation. But I did maneuver her. I tried the standard modified epley, even with that little extra head turned down, like I just showed you, didn't clear it. I tried what's called the Samant, which I'm about to show you. And that didn't clear it either. So this is the Samant. You lay them. It's kind of like the Bascal, but a little bit differently because you reverse which one goes first. But anyway, I tried the Samant, which is a very classic maneuver also, in case they're stuck. This could be really helpful. Didn't clear it. So I'm like, all right, this is it's acting like regular posterior canal, but it's being stubborn. So if it's being stubborn, we've found that sometimes bringing them into full extension with the deep head hang can help free them where they're kind of getting caught or stuck on one of the edges of the canal somewhere. Even though it looks like they're just kind of floating, maybe they're a little bit stuck too. We might have to really get a lot of neck extension and really drop the crystals. So I think if you could take something home from this whole talk, it's don't just keep doing the epley. Try the epley. If it works, great. If it doesn't, go to plan B, C, D, and E. There are options. And if it's not clearing with any of those, think about the fact that it might not be BPPV. This is what we need to do for our patients instead of kind of, oh, I went to this, clinician and they did 60 epleys. Like, no, that ain't it. Something's not right if we're not clearing it with that. All right, so we can use this deep head hang, convert it. They think what's happening is sometimes it's caught in the short arm and then it'll drop down and it'll convert into long arm. And then we can do a modified epley right after the deep head hang, and then we'll clear it. And actually that worked really well for that lady I just showed you that didn't clear with our classic maneuver pattern that I usually do. And there's another one out there that Ludwig and Schubert found. I mean, they didn't design the maneuver, but they found that it cleared this kind of stubborn case. It's called a demi-Samant. So we have so many choices. And if you ever see a nystagmus and you're like, this looks like maybe it's stuck in the short arm, right? This is our kind of our downbeat nystagmus here. Oh, that's so dark. I'm sorry. Anyway, there's a downbeat going on here. So I'm saying to myself, this isn't really acting like it's going to clear. Why do we have this downbeat? I tried a maneuver or two. I even tried something fancy like the demi-summant, nothing. Let's make sure we're always going back to, does it reduce with fixation? So this is turning on the fixation lights in our goggles. Another really helpful piece of the goggles is that you have these little lights inside that you can turn on. So you just flip these switches on the top and the lights come on. And if it's a nystagmus that's coming from the brain, that nystagmus probably won't diminish in strength. If it's a nystagmus that's coming from something like BPPV, that nystagmus will diminish or go away. So in that patient I just showed you, when I put in those lights, that downbeat that I thought maybe was like a short arm posterior canal, it didn't change that nystagmus. And now I'm like, ooh, now I'm suspicious for a brain issue. And actually, in that particular case, like 12% of patients who get nystagmus with a positional test, they had a brain issue. And actually, she fit the criteria for vestibular migraine. So I was able to sort out that even though I was getting a nystagmus that I thought maybe was BPPV, it was actually vestibular migraine talking, I like to say. So again, going back to this, if we do 1 to 3 sessions of well-applied maneuvers for a simple case where I think it's just floating or it's just one canal, and that should clear. And if it doesn't change, I should go back and think, are they fitting any other criteria? Is there anything else going on that might be think this is not BBV, this is something else going on? Um, and if it's a tough case, multiple canals, or it's stuck, maybe it'll take me 3 to 5 sessions maximum. But after that, I should always be going back and thinking about, is it fitting the vestibular migraine criteria, for example? And she did fit those well. And so I referred her properly to a neurologist to get medical workup to make sure that we weren't thinking that it was migraine, but it was actually a tumor. It turned out it was just vestibular migraine, but they had to check that out. And then also give her medical management for the migraine piece, which again wasn't about a lot of headache. It was more about dizziness. And then we can work on lifestyle education to help reduce the recurrence of vestibular migraines and vestibular rehab for balance, neck care, gentle habituation to visual motion or self motion. All these things are beyond the scope of the talk. So I've got tons of resources for you. You're like, Helena, I need more practice watching eye movements and figuring out what I'm seeing. Here is your slide. You're like, Helena, I need goggles. Get a demo. I got you covered. I'll take care of you. If you're like, Helena, I need courses. Tons of stuff we have coming out of vestibular first, differential diagnosis and atypical BPV coming out this January. We're going to have a 5-part series releasing throughout next year, which will be a novice ready to treat. So that'll be great for y'all. We're going to be doing some in-person courses come 2026. But if you're like, I don't want to wait for all that, there's other people. They're doing awesome teaching too. These are some of my favorites, really depending on what level of learner you're at. If you're like, I just want to know how to do an epi myself at home, well, maybe you should get somebody to check out, make sure you have BPP. But here are handouts available on our website, and for clinicians to give to patients if it's appropriate for them to do a home maneuver. Tons of educational resources for you as a patient, or if you're a clinician, you want to share these with the patient. Wonderful ways to learn more than what I have been able to cover in this talk. How do I find a vestibular PT near me or an expert in vestibular care? Here are your resources to find somebody. And we're working on Dizzy Care Network. It should be out the next year through Vestibular First to help match clinicians with patients because this is needed. And if you're like, I have vestibular migraine, or I think I do, I want to learn more, here's your resources. I got you covered. And this is me. So if you just want to reach out to me directly with questions or watch our free journal clubs on our YouTube channel, everything's available to you. I am happy to help. Whew.
That's a that's a nice headdress as well, and then that's a rough like closing. That's wonderful. Lots of resources there, Helena. That's wonderful. Thank you so much. And I believe you said we can grab that PowerPoint. That way they can follow, and then I will be able to maybe highlights as well some of those resources. But if it is available in PowerPoint, definitely maybe they can hyperlink that as well, or they can.
Absolutely.
Okay, good, good.
Yeah.
So because that lots of hyperlink there. We have a couple of questions, but that's amazing. PowerPoint, very nice. I keep taking pictures because it's really nice, all those diagrams. And sorry, I keep moving my
No, I
head.
love it. I love it.
I
As long as it's
distract you
helpful,
with.
that's all I care about. I just want to, help everybody to feel empowered because again,
Mhm,
vertigo can be tricky. So, whether it's a clinician or a patient, the
mhm,
more you know, the more you can hopefully do the right next step. What's the right next step for me? And that's what you're all out there figuring out. And so I'm happy to help guide you, and I'm happy to answer questions. And then we're going to let Mike, I don't want to interrupt Dr. Studer. He's awesome, and I don't want to cut out a minute of his time. So let's answer
Yeah, we have
questions.
QA here. Do you have access in the QA?
Yeah, so I'm just
Okay.
going to read them out. Can we
Mm-hmm.
use the universal maneuver if the diagnosis is clear? So universal maneuver is awesome. It's for either horizontal or posterior canal, as long as you know the side. It's a newer maneuver, so I didn't really cover it because it has less research on it yet, but I think it's worth a try, especially if you're not getting a result from some of the other more kind of well-studied maneuvers. So absolutely try that universal maneuver if you feel like you have a clear diagnosis. And how many repetitions of treatment can be done per session? That is about patient tolerance. And how much time do you get? So I get my patients for an hour. So let's say it's a follow-up visit. So the first day I'm just figuring out what's going on. I only usually have time for 1 or 2 maneuvers at the most. Second time, let's say it's not cleared yet. I'll do a maneuver. I absolutely need to rest them 10 to 15 minutes, not just to let their symptoms settle, but so that we don't get a retest that's a false normal, because that your brain will try to suppress the eye movements if you keep testing like right away. So I wait 10 to 15 minutes. I'll test again. Still, I have seen nystagmus, and I think I haven't cleared it yet. I'm going to do a second maneuver if the patient's tolerating it at okay. And so the most I've ever done in a session is probably like 4 or 5 in a session. But that's really for a stubborn case, of course, or multiple canal, maybe something like that. So that'd be the maximum I would do. Hopefully that answers your question there, Mr. Rahman. And then we got a question on the Iacovino for short arm, posterior canal, and for anterior. Yes, so the Iacovino is the deep head hang. They have 2 names, like a lot of things in vestibular, unfortunately. So it is an appropriate treatment for either short arm or anterior canal as well. So great question from Cohen. I don't know, if you're
Mm-hmm.
Mr. or Mrs., doesn't matter. You're a person, you're awesome. All right. Deja, I know, so I could say her name. Would you refer vestibular migraine patients to an audiologist or a neurologist? So if I think they might have signs of Meniere's and I'm not sure, I would love for them to see an audiologist to get that hearing test, just to kind of have that information. Even if their hearing is normal, if they keep having episodes and they kind of notice some hearing changes, and then we do another hearing test like 6 months or a year later, and we see that low to mid frequency hearing loss, what we thought was vestibular migraine might have been Meniere's, because they can definitely mimic each other. We actually have a whole course on that just because they're so complicated. They can really mimic each other. And some people have vestibular migraine and Meniere's, which isn't cool either. So, so definitely, if they're describing hearing symptoms, get at least 1 hearing test. Otherwise, if it's just more purely a headache, dizziness, I'm pointing right to, usually it's a neurologist. Some ENTs actually specialize in vestibular migraine as well. So it's not as much about discipline as like who's comfortable treating vestibular migraine, because not every neurologist is. So you got to kind of try to find the people in your area, or refer to somebody like Shinbei, who will see people doing a telehealth. That was on my list. All right, I think I hit all the questions.
Mm-hmm. Yeah. Yes, we have the webinar chat, so you can put it on the QA chat and the webinar chat as well. Thank you so much. That's lots of informations. Thank you for sharing the new evidence and articles that was outside nowadays. I took picture because the diagram really are very helpful in the position. So those
Yes.
positioning are very important and very sensitive for us to really rule out something, and also to perform the test nicely and perfectly, right? Although it's not really perfect, but we just want to get those symptoms. And then those resources will help us a lot to build more confidence to learn more. Because as what I've said, I really always want to have vestibular rehab in all my summits, either geriatric rehab and innovator, because we have less clinicians more confident enough in vestibular rehab. But at the back of their mind, I really want to. That's why I always want to invite our you guys vestibular rehab. We have lots of dizziness with our previous speakers as well, American Institute, and we always love to learn more from different clinicians. So thank you so much for this. Any closing remarks? You already said the resources, and then kindly put there, Helena, where they can find you, or at least an email,
Oh,
all
of
right?
course, of course. I'll put
Thank
my email
you.
into the webinar chat. Okay.
All
And
right,
thank you,
guys.
everyone. And right to Dr. Studer, because he's awesome. I don't want to take a minute of his time. You want to hear everything he has to say. He's brilliant. But thank you guys for having me.